All right, welcome to the pulmonary section. And why is pulmonary important? Do you know that there's roughly about 16 million Americans in the United States that have chronic obstructive pulmonary disease, COPD? This is about 6% of the population. Crazy when you think about it. So why do we have this pager here? What's the deal with this pager? This is a pager is to remind us that roughly between 80 to 90% of the hospitals still use pagers. And this is an outdated technology. Drug dealers don't even use these anymore. So even though we do advanced things in medicine, for whatever reason, we're very slow to adopt new technologies and even new ideas. And I know that your Kung Fu is powerful, and I know that you come from a hospital that you shoot lasers out of your fingers, and in your clinic you can get cancer by just chopping things with your hands. But you have to remember, for the rest of us, is that medicine, even though we're progressive and we've become leaps and bounds, we're still holding ourselves back. And anytime you think that you're not, is that we're not as advanced as we probably should be. Think about that pager that may be in your pocket, or that pager that the other provider that you hear is getting buzzed on, and realize that we're not as cutting as we'd like to be, cutting edge as we should be. All right, we're going to talk about the pulmonary exam. So we're going to talk about physical exam, and the reason why boards like it, why it's cheap, it's easy, it helps you get to diagnosis. You should be touching your patients. I know it's crazy. You need to get out of the whatever room that you're sitting in and go and touch your patients. So tactile firmitus, that's a palpable vibration felt on the chest wall. Increased firmitus, so in pneumonia. Decreased firmitus in COPD. Just think about this. In pneumonia, you're going to have fluid in there. You're going to have a vibration. Air is not going to conduct those vibrations as well. So remember, the chest is going to be, the lungs are going to be open up bigger. In COPD, you're not going to have decreased firmitus in pneumothorax because you have air in there. The balloons are broken, and you have air as a pneumothorax. So feeling for this palpable vibration while the patient breathes in and out. Now, for percussion, is tapping. Okay, so when you have dullness, so you're tapping on the surface of the lung. You're tapping. You're going to have dullness in pneumonia, for lobar pneumonia, for pleural effusions. Hyperresonance in COPD, because the air is going to be, there's going to be more air in the lungs. We're going to make it simple. We're going to call more air in the lungs, and you have hyperresonance. Pneumothorax, same thing. And signs of a consolidative process, egophony, is when normally you have the patient say E, and then you're listening to it with the stethoscope. If it's a consolidation, have I. So a patient with pneumonia, if you say, in the questions says egophony, during egophony, and they're saying E, and then the consolidation has an A sound, that means that there's a consolidated process. Whisper pectorally, which is normally only hear faint sounds. In the consolidation, they'll be clear and distant, because distinct, because these patients, they're going to whisper a sound, and you're going to be able to hear it because those fluids are going to be able to transmit those sounds. I know this sounds old and outdated, and it is, just like we talked about in a pager, because the chest x-ray and having ultrasound can clear these things up right away, but they're still tested. Now, these sounds, we're going to go through the breath sounds, such as wheezes, is going to be high-pitched, continuous sounds. You're going to hear this in asthma and COPD, so let's actually listen to those sounds. You hear that sound, that wheezing sound? Let's do it again. Now hear that sound. Wheezing sound. You hear that sound. Ronchi is low-pitched, continuous musical sounds. Okay, ready? Here we go. So low-pitched, continuous sounds. Low-pitched, continuous sounds. We'll hear it again. Almost sounds like a whale. Bronchi. Whale sound. Whoa. Now, we discussed this before, just a quick reminder, RALs on physical exam went bye-bye. Now, I know you can go into your high dollar EMR and you'll have a button in there in the physical exam section that says RALs. RALs went away in 1977. Ray Laennec, who invented the stethoscope in 1816, it was a mistranslation from his writings in French. Mistranslation, that's all. We carried it forward. Just like that pager that we're carrying around, we carry forward our mistakes moving forward. So guess what? Standardized by the American Thoracic Society and American College of Chest Physicians. They got tired of people saying RALs, so they said, guess what? We're going to have crackles. They're going to be correct. This is going to be more correct, coarse or fine. And yes, I know the EMR still says RALs, but it's incorrect. Just have that realization. Crackles are popping sounds, a passage of air through secretions in the airway. We can have fine, which we're going to listen to the fine right now, or coarse. High pitch, low amplitude, short duration. Now coarse, let's listen to crows. So longer duration, lower pitch, high amplitude. Plural rub is like rubbing your stethoscope against cotton. You're going to hear this sound. It's an inflamed pleural surface rubbing against each other. Stridor is going to sound, high-pitched sounds usually produce an upper respiratory tract obstruction. You would put your stethoscope up here. Remember, you have to take your stethoscope out of your car that's hanging on your rearview mirror because you look cool with it on there, so everybody knows that you're cool. You have to take that out, put that on your shoulders, walk into the room with it. Crazy, crazy concepts. Hear that high pitch. We're going to listen to that one more time. This is a sound that you need to know. We'll listen one more time. Why is that sound important? We talked about it before. You can have the greatest lungs in the world, greatest mouth in the world, but if you cannot get that tube to work and that tube has a blockage in it, you're not going to have great gas exchange and things are not going to go well for you. All right, fingernails and pulmonary disease. Where we can have clubbing, we're going to have increased curvature of the nail plate, clubbing. So normal concave is at 60 degrees. Clubbing is more 180 degrees. Instead of 160, that's 180. What diseases can we see this in? Cystic fibrosis, COPD, TB, lung cancer, congenital heart disease, inflammatory bowel disease, and cirrhosis. You're going to have high VEGF levels. High VEGF levels is going to cause that growth right there. So if you're able to reduce the VEGF levels, clubbing reduce. Reduce the VEGF levels, the curvature, the increased curvature of the nail plate or clubbing are reduced. Now, what is an anti-VEGF? Bevacizumab is an example of an anti-VEGF. All right, now we're going to look at lung slide. And what we're doing is we're getting our probe from our ultrasound. We're going to get this, on this one, we're going to use the linear probe. So it's just a straight probe. We're going to put this on the lungs and we're going to look at this. If there's lung slide, there's no pneumothorax. So the whole purpose of this is you can be on wards, ICU, or even in your clinic, and you suspect the patient has a pneumothorax. In that suspicion, you can't get, it takes time to get the chest x-ray, it takes time to get the chest x-ray read. This is a test that has high sensitivity and high specificity for looking for pneumothorax. So see that lung sliding right there? Well, let me draw this on there. I want you to see, this is the lung with the pleural surface. They're moving back and forth. Let's go back to that. See how that's sliding back and forth? sliding back and forth. There's no pneumothorax when you do it. Now you need to get to about the 8 different points on each side, so 16 different points you can do on both sides. You're looking for the lung side. Now here's an example of the lung side when color is placed on the probe, meaning that you get Doppler. Anytime you see that color towards the end, this isn't a great example, but let's show you right here, is color just shows movement. So if there's movement, see that lung side? If there's movement, the color will appear. So that gives us a high probability that they do not have a pneumothorax. This is the one we discussed before, is where you're using M mode on your ultrasound. So M mode basically means is we have our probe. In this case, we're going to use a linear probe. M mode is we're going to focus all that energy at the point. You're going to see a kind of a point or a dot or a line on your ultrasound probe, and this is where it's a faces. And this right here, this is called the barcode sign, where it looks like a barcode, and this is a pneumothorax. So if they gave you a still picture of this, they would say, you would look at it right away and you say, this is a pneumothorax. On this one is where we've done the M mode, and then we have what's called, you can just imagine this right here, it's called sandy beach. See this right here? Here's our beach on both sides, and then here's our waves right here, sandy beach, and we've ruled out having a pneumothorax. We can also use this ultrasound probe to look for pulmonary edema. And this is where we would usually stick as a phase array probe. That's kind of the roundish probe, and we put that between the ribs. And we look for B lines. They're vertical echogenic wedge shape, and you can see these right here. Let's go right here. Here's a web shape. Dynamic lines that originate from the pleural line. Okay, so up top is the pleural because you're putting right here, you're putting the probe on the top on the pleural surface. If you have four more B lines and seen in 2 or more zones, so you go from here to here, 2 or more zones in the lung, it's a high sensitivity for pulmonary edema was 100% and specificity was 92%. The positive likelihood ratio of 12.5. Now, does that tell you the difference between pneumonia or pleural fluid? No, it doesn't. Is this can be pulmonary edema? It can be from heart failure, or is it pneumonia? The only way you're going to know is by if you can find a pleural effusion and pull it out and send it to the lab. Otherwise, this is not going to give you that information. It's showing that you have fluid and volume overload. You're showing you have fluid in the lungs. If you have these B lines, if you have 4 more B lines, and it's seen in 2 or more zones. So they can easily give you a picture like this, and you can easily count as there's 1, here's 2, 3, 4, we could say 5, 6, 7 of these lines. That would be very conducive to having volume over the lungs. We don't know if this is from pneumonia or is this from volume overload from, say, heart failure. All right, let's talk about furosemide in the lungs. And you're saying, well, what are you talking about? Furosemide and the lungs. Well, loop diuretics were invented back in 1964, and the janitor even can tell you that this works in the kidneys. But does it really? Does it just work on the kidneys alone, or does it affect other parts of the body? So it actually works in the lungs too. Yes, it mainly works in the loop of Henle, but it can work in the lungs. So it takes about 5 minutes to have effects in the lungs. Now remember, it takes 30 minutes to get urine output. So there is a change with furosemide and in the lungs. It causes venodilation in the lungs, it increases prostaglandins, and inhibits prostaglandin dehydrogenase. It is a bronchodilator. So furosemide does affect the lungs. Now we talked about when we did our SCAPE class, a little case study, and we talked about how we wanted to wait. In that situation, we wanted to wait because we're going to open up things with our BiPAP, but furosemide does affect the lungs. And so it's kind of an interesting thing that we think, things that we don't think about. So here's another example to show you what they can show you on boards of having a pleural effusion. And see this right here, all this right here? That's your lung right down there. This is your surface of your probe and your skin from that surface. In between here, this is pleural fluid. See this dark right here? It transmits differently. This dark fluid, it's showing that there's fluid in there. It transmits differently back to that probe. So this shows that we have a pleural effusion. This is actually a pretty good sized pleural effusion. And from here we can do a thoracentesis and take this fluid out and then send it to the lab and try to figure out what's going on with this fluid. What's going on with this patient from the fluid analysis. All right, this is a nice little diagram that gives us the different types of lung inflammation. And we'll look right here is when he has inflammatory injury of the lung parenchyma, so pneumonitis. This causes can be infection, autoimmune, trauma, or medication. So pleuritis is inflammatory injury of the pleura. That's the tissue surrounding the layers of the lungs. So right here, pneumonitis is going to be the parenchyma. This is going to be right here, the inside parts of the lung, and then the pleuritis is going to be the outside. We come over to the middle. Here is bronchiolitis, is inflammatory injury of the small airways, 2 millimeters or less in diameter. And then bronchitis is inflammatory injury of the large airways, And we come over here to pleural effusion that we just look at on the ultrasound imaging. It shows a fluid buildup between the pleural layers, usually secondary to inflammation of the pleural. And causes can be transitate or exudate, and we'll talk about intransitate is more from CHF, cirrhosis, and nephrotic syndrome. Exudate can be infection, malignancy. So these are things, this gives a good representation that we can look at diseases of the lungs pretty rapidly, because sometimes I can see learners getting confused. Now let's go and talk about exudative effusions here. Exudative effusions. And when you think about this, this is the Light's criteria, and this was developed by Dr. Richard Light. And let's give a minute to really kind of talk about how great this is. Well, when he initially presented this, and guess when he did this? He worked on this while he was a resident. Can you imagine creating a criteria that's in 1972 and still holds weight today and is still used in facilities around the globe today? As a resident, this gentleman invented this. And you know what? When he did his oral presentation, they said it was okay. They got average marks for it. Nothing to suggest that these cutoff levels that he developed working as a resident, and it said this in the literature, he worked on this at night as a resident, as and as a resident. Remember, people used to be residents of the hospitals, used to live in the hospitals. So we have to honor these giants and the sacrifice that they made, that we stand on their shoulders. Can you imagine as a resident that you are inventing something that's still going to hold true 40 years later? Wow. I want you to start thinking about stuff like that. It's thinking about the past, because the past leads to the future. And we take so many things from the past and we take it for granted. The failures too, we learn from failures just like we learn from our successes, okay? And these individuals worked so hard and did so much, we have to honor and respect them. All right, so there's 3 criteria. If they meet 1 or more, they have an exudative effusion. So Light's criteria for exudative effusion. So taking out the pleural fluid, remember we took that pleural fluid out when we showed you on doing a thoracentesis. If the ratio of the pleural fluid divided by serum protein, that's from the blood, is greater than 0.5, it's an exudative. If the pleural, we're pulling pleural LDH is greater than the ratio of serum LDH, we're going to take out the blood greater than 0.6. So we divide the pleural fluid LDH divided by the serum fluid LDH greater than 0.6, we have an exudative effusion. If our pleural LDH that we took out from our thoracentesis is greater than 2/3 the upper limit of normal of serum LDH, we have a exudative effusion. Now, how sensitive is this? Sensitivity is great, about 100%. Now, specific is about 83%. It's going to misclassify roughly about 20% of the patients as exudative when they truly have heart failure. Now, what can cause us to have this misclassification is diuretics, and we'll talk about how we can use another formula to kind of keep this. But mainly, this is a good criteria. This has worked very well, and we still carry it forward. This is excellent work when you think about it. Let's go back to one more thing, and I just want to bring this point up. Is when he did this criteria and he brought it to the American College of Physicians in 1972 and he did his oral presentation in Atlantic City and they said, it's okay, here's an average. Guess what it is he was able to persevere. He was able to persevere and give us this great criteria in spite of opposition against him, in spite of obstacles that were presented in front of him. This is what we need to do. We need to persevere through our difficult times. I know I'm preaching, but here again, this is an important fact we need to learn in our careers, in medicine and other aspects of life.